I'm really very much a storyteller. So I love telling stories. Some of you read my articles in Mind Your Body. I do it the last Thursday of every month, where I normally talk about cancer patients and their struggles. Some are stories of encouragement, some victories, and of course some defeats. Are you having difficulty hearing me? They can't hear me. Can you hear me? Can we up the volume a little bit? I have a loud, booming voice, you know. Everybody can hear me. Are you all right? Okay, my microphone is not working well. Is this better? So I can't move. Oh, I like walking, you know. That's the problem. Okay, it's all right. I'll stand here and talk. I'll try and be different this time round. So today I've titled my topic, Stories of Hope, the past, the present, and the future. It's okay. I don't like holding things. For me, I'm not that old. I don't know how old David is. I'm only 18. I started off, I finished medical school in 1982. I finished my internal medicine, and then I met up with the Permanent Secretary of Health, Dr. Kwasun B. He asked me, look, what do you want to do? So I said, I want to do cardiology. So he said, why cardiology? I said, well, all the smartest people go into cardiology, and I believe I can be as good as any one of them. Then he told me, he said, look, in Singapore, a lot of people want to be cardiologists, but what we really, really need are medical oncologists. He says, I can see the trend. There are going to be more and more cancer cases. We need people with intelligence, with leadership qualities, to start developing this field. So I said, but there's nowhere to train in Singapore. In Singapore General Hospital at that time, the total number of oncologists was 0. Okay? We're not talking about a long time ago, we're talking about 1986. Okay? There were no medical oncologists in Singapore. In Singapore General Hospital. So he said, why don't you go there and start, find your way around, study a few cases, We'll give you all the opportunity, the resources. We'll give you all the opportunity and the resources. They can't hear me. Now I can walk? Okay, good. So he gave me the resources and he said, go ahead and try and develop this field. So I still remember, all right, I was put in the Department of Internal Medicine, and the only practicing cancer doctor was a hepatologist, Professor Un Chong Jin. And all I got to see was liver cancer. All he knew how to treat was liver cancer. And I still remember my own very first cancer patient. Really. He's a young man. He worked in a company called Honeywell. I think it's a big company. I'm not exactly sure what it does. Something to do with agriculture and equipment and so on and so forth. And he had stage 4 colon cancer. And at that time, he said, look, doc, you're the only doc I had, doctor that is around, give it a try. And I went and I started reading books and so on, and reading all the journals. And I came out of this program, that was being used at that time, 5-FU leucovorin, high doses of folinic acid, and reported 20% response rate. And truly, truly, that was the only option he had. He took the treatment, he had a modest response, and I was so happy to be able to help just that one individual. Just see the response, the tumor marker coming down, to see on ultrasound some improvement. It was fantastic. But he died. All right? It didn't last long. In those days, if you could achieve 12 months for stage 4 colon cancer, they say, good job, you've done a good job. So I consider myself having done a good job. And after 6 months, I went to Dr. Kwa and I said, look, I'm ready. I'm committed. I'm ready to go for training. He gave me a scholarship, and I went to MD Anderson after I got a job at Stanford University, and I went to do the fellowship there, and I came back in 1990. I always joke, I'm oncologist number 5 in Singapore. There were 3 in the private sector. I was alone at Singapore General Hospital, and there was another oncologist at the university. So there were 5 medical oncologists in the whole of Singapore at that time. The basic approach towards cancer treatment has remained the same. Make a diagnosis, determine what is the extent of cancer spread, plan a strategy, and if the strategy involves chemotherapy, select the appropriate drug, and do your best and provide the best psychosocial support for the patient, because that's what they need. In the old days, when it came to diagnosis of cancer, it's very simple. You look under the microscope, the pathologist looks at it. These cells are obviously not normal. These are cancer cells. If it comes from the liver cancer cells. If they come from the lung cancer cells. Very often we are able to subtype it just by the appearance of the cell. Today, it's completely different. The pathologist will speak a completely different lingo because we have begun to understand beyond just the appearance of the cells. We know the markers, the oncogenes, the molecular genetics of the cancer. And all this has helped to guide us in our management. So when we talk about personalized cancer treatment, that's what we are talking about. We are not just saying that, look, all lung cancers are treated the same. They're not treated the same. You have to take into consideration various aspects, the age, the stage, the genetics. Like, for example, as I said, in lung cancer, these two mutations are so important, whether you find this EGFR and ALK. Because if you find it, the treatment is different for a person who has the mutation and a patient who doesn't have the mutation. Way back in 1986, there's no such thing. It's either chemotherapy or nothing. In fact, there was no chemotherapy. You don't have any choices. So whether you've got wonderful mice that grew or didn't grow, it made no difference because there are no drugs. If there are no drugs, what's there to choose? But medicine has changed tremendously as the story goes on. So very important, we need histology. In other words, we need to take a biopsy, we need to take a specimen of the tumor. And from there, they will examine it and give us as much information as possible. If it's a breast cancer, is it estrogen receptor, progesterone receptor positive? Does it contain the oncogene called CRB2? All this will guide us in our management of the patient. That's why we call it personalized medicine. With a simple needle biopsy, within 30 minutes, the pathologist will tell me, yep, this is a cancer cell, you better start planning, do your staging, do the necessary. So to reach a diagnosis and come up with a treatment plan, we have set for us a very simple standard. For 90% of patients, we should be able to finish achieve a diagnosis, finish the staging, and come up with a treatment plan within 48 hours. So within 2 days of patients making contact with us, for 90% of the patients, we should be able to reach a firm diagnosis and offer them a treatment plan. The pathologists are now go far beyond just looking under the microscope and telling us what it looks like. They give us a great deal of information which is very useful in the way we plan the cancer treatment. The second step is obviously to determine whether the cancer has spread or has not spread. And that's why you have to have a good team of radiologists. The radiologists have made our lives so much easier because they are often able to help us do biopsies. These are called interventional radiologists. If you have a lesion in the liver, you don't really have to go in and operate to reach this lesion. Often they can stick a core needle inside, take a sample, and then you'll be able to have the histology. But in the staging, we are all familiar with some of the plain X-ray, ultrasound, CT scan, and so on. But obviously, the latest that we have is the PET-CT or the PET-MR. What is PET? Most of you are familiar, but some of you may not be. The machine looks exactly like a normal CT scan machine. You lie down, you go there, go inside. Within 30 minutes, they'll be able to scan you thoroughly. This is a CT scan. It basically shows you, this is the backbone, this is the liver, the gallbladder, the pancreas, the kidney, but you can't really tell where the cancer is. But in a PET scan, they will inject the tiniest amount of sugar tagged onto a radioactive substance. And they know that these active cancer cells has a fondness for sugar. And the sugar will go to where the cancer is and help us to light it up. So you can see, this may look like a normal pancreas to you, but in actual fact, this is a pancreatic cancer that's hiding inside the body of the pancreas. Another example, this is a patient, you can see there's a CT scan of the pelvis, looks perfectly normal, but this little dot here that looks perfectly normal is in actual fact where the cancer is hiding. The next step is planning the treatment strategy. This is where it doesn't matter whether you're a surgeon, a radiotherapist, or medical oncologist, you should be aware of what are the options that are available, all right, to guide the patient. In difficult cases, we sometimes have tumor boards to sit down together and really discuss and see what is in the best interest of the patient. Surgery has been and is often still the cornerstone to the management of cancer. Meaning that much as we have developed new drugs, new radiotherapy techniques, you still need the surgeon because they play a very important role, especially if the cancer is localized. Radiotherapy is very important in diseases which are radiosensitive. For example, in nasopharyngeal cancer or nose cancer. And chemotherapy is, of course, used as a form of drug treatment to treat systemic disease. In other words, you aren't really bothered whether the disease is hiding in the lung or in the liver. The chemotherapy drug will help you to take care of it. One of the biggest advancements in cancer surgery is really understanding the biology of the natural store history of the cancer. In the bad old days, we always thought that the bigger the operation, the better. You know, they didn't just take out the breast, they had to take out the muscle, they had to take out the many deep layers to reach all the way to the rib. The further they did the operation, they thought the better would be the result. But it's all found to be untrue. The cure rate is not dependent on how radical or how aggressive your surgery is. You just need to be clean. That's good enough. So for some women, this may involve a total mastectomy, meaning removal of the whole breast. But in actual fact, the data has clearly shown in the smaller tumors, you don't even need to take out the whole breast. You just need to take out the lump, sample the lymph nodes, and add radiotherapy to the breast. The results are equivalent to having a total mastectomy. The surgeons have improved tremendously. They're often able now to do cosmetic surgery. In other words, the patients, even who may choose to have a total mastectomy, can still have reconstruction. Whenever the program requires for chemotherapy to be incorporated, then it's up to us to use our experience, to use the medical literature, the data, to guide us in terms of how to choose the drugs and when to deploy them. This is an example of a patient I saw more than 10 years ago. A massive tumor involving the cheekbone. The surgeons are really good. They can literally tear the face apart. You can see this is the nose, the eyes, the teeth. They just strip it open. They remove the tumor. And much as you think that this patient had gone through a horrible time, this patient was cured. So there's nothing wrong with surgery. Surgery plays a very important role when the disease is localized. But this is only a cheek. What does your cheek do? Very little. Okay? What if you had a cancer of your voice box? You know, your larynx. If you had surgery, it would mean that you will not be able to talk. You won't have normal speech again. And that's why when we think of it, there's nothing wrong with surgery, except that when the disease is in certain sites, the surgery can be very morbid in the sense that you can end up with a lot of morbidity. You can't talk, you can't swallow, and so on and so forth. So that's why we have always thought of new ways in treating these patients. And one example is Madam Tan Siu Ing. These are real-life examples. They have given permission for their stories to be told. And in actual fact, all these nice pictures are not taken by me. They're taken by professionals because we did a calendar 2 years ago. And all the family came along. We all did a photo shoot, and we had this wonderful calendar that was put up for each of them, for the patients. And it's really not advertising. It's really to encourage other patients in similar conditions to know that cancer is not a death sentence. When I saw Madam Tan, she was already in her 70s. She doesn't know how to write. She doesn't know how to read. She speaks. Okay? And when she was found to have a cancer involving near the voice box, the option that was given to her was the standard one. Go for surgery. But in her mind, she says, look, I can't read, I can't write. If you take away my voice, how am I going to communicate? How are people going to understand me? He says, look, at this age, what do I fear? I'm not afraid of death. If I have to die, so be it. But I certainly don't want to live the remainder of my life not being able to talk to my children. Okay? And the interesting thing was that when we interviewed her, we said, do you have a lot of things to say to your children? She says, no. For her, we started her on a chemotherapy program, all right? It responded marvelously, as you can see on the MRI, you can see the tumor, all right, and how well it responded to the chemotherapy. She went on to radiotherapy, and till this day, she's alive. I just saw her before Chinese New Year, and I really love the love letters she cooks for me. They're very good. So you can tell These are patients who have fought cancer and beaten cancer. This is another example. His name is Daniel Steele. His name, he's not the writer, the famous writer of novels, Daniel Steele, but his name is the same. And he talks for a living. He says, I talk for a living. Every day I talk. You take away my voice, I'm done. And he was discovered to have very advanced cancer of the tongue in the posterior 1/3 with involvement of the cervical lymph node. The option that was given to him was a subtotal glossectomy, meaning removal of more than half the tongue with all the dissection of lymph nodes. And he says, look, I'll be finished. You know, no one will hire me. I won't be able to talk properly. But again, for him, we gave him the option of the chemotherapy followed by the radiation, and he too has beaten the disease. Now, so you think, wow, we're doing fantastic. That means that, what's this lecture all about? You know, we don't need a professor here to tell us about what the future is. The present is good enough, but it's not. For indeed, we do have many patients that despite our treatment, you can see they may have marvelous responses, but they still recur. Patients like these, you can see a tongue cancer that was operated, came by recurrent disease. We did a marvelous job after chemotherapy, but he's no longer with us. He has died because the disease often recurs. While some are indeed cured of the disease, there are still significant numbers that do not win. Nasopharyngeal cancer is a very common cancer in this part of the world, and radiotherapy plays a very important role. Now, if you know where the nasopharynx is, the nasopharynx is sited right between the eyes, all right, behind, in front of the brain, below the brain. So it's in a very vital area. If you want to give radiotherapy and your shooting is not accurate, you're going to damage the eyes, the nerves, the brain. You may not be able to talk properly. You may not be able to see properly. So that's why it's so important that technology, the advances in technologies have helped us tremendously. And this is the Tomotherapy Machine. All right? The tomotherapy allows us to do a daily calibration of exactly where the tumor is and to shoot the radiation beams to a narrow field, hitting the target and sparing the normal structures. And that's why we have got many patients who have got very advanced cancers that we strongly recommend for them to have radiotherapy. In radiotherapy, it's all technology. If your machines are good, if you know how to use it, you're going to get better results in terms of better cure rates and less morbidity. One day is a very nice story. He came to see me in 2004, but in actual fact, his cancer was diagnosed in 2002. He was seen by a doctor in Indonesia and told to go undergo radiotherapy. He was very fearful. He heard about all the side effects about how your skin turns black, you can't swallow, you have no more saliva after that, and he basically ran away. He tried herbal medicine, and he was conned, basically. He went to see this famous Chinese physician who told him, you take 100 capsules in the morning of my herb, 100 in the afternoon, and 100 at night. He took, and the tumor grew. So he went back to see the Chinese sensei, said, Sensei, I've done what you told me to do. I've been taking these 300 capsules every day. My cancer is growing. What do I do? He says, don't worry. I've got this electromagnetic bathtub. I'll soak it with water, I'll put in herbs every day. You take those 300 pills, and you come here, lie down on my bathtub. We will attack the tumor from within and from outside. He did it. And the tumor grew. And then he asked, Sensei, it's still growing. What do I do? The sensei says, don't be so impatient. Cancers must grow before they die. When finally he couldn't turn his head anymore, he came to Singapore. And I told him, I said, look, obviously, you're in a bad state. And with the treatment, you can see after 3 cycles of chemotherapy, he had a marvelous response. And to this day, he's still alive. All right? His story is told in my book, which I wrote, called Doctor, I Have Cancer, Can You Help Me? I'm not selling koyok. These are books that are intended to explain the journey of various cancer patients. It is to encourage people in their fight against cancer. I think it's available outside, cheap. I don't exactly know how much, but I'm sure someone will tell you later on. This is a Vietnamese gentleman who, after the war, went over to Canada. What do they work as? Cooks, obviously. And most of them went there. And he kept complaining to the doctor. He said, look, there's something wrong with my eye. There's something wrong with my eye. They couldn't find out what's wrong with his eye. They kept checking his eye and everything looked okay. Until one day, his eye couldn't open anymore. Then they said, I think there's something wrong with your eye. He said, I told you so. And when they peel open, when we force open his eye, we turn to look to the left, you can see the eye doesn't move anymore. It's paralyzed. You tend to look to the right, it doesn't move anymore. You look up, it doesn't move anymore. You look down, it moves a little bit. In other words, the third nerve and the sixth nerve have been damaged by the tumor. He also had a nasopharyngeal cancer, a nose cancer. And instead of going down, like in the case of Iswandi, it went upwards, hitting through the base of the skull and affecting the cranial nerve. And again, we deploy the same program, chemotherapy first. Okay, you can see the good response, and you can see he recovered fully from his illness. So we have many, many examples with NPC which are treated with either radiation alone if the disease is localized, or combined chemoradiation with excellent results. So this is one area whereby I believe we have made good progress. There will be some patients with NPC that will still fail despite our best efforts, but this will be the minority. Lung cancer is a different story altogether. All right? The lung cancer story is a very, very sad story. If you look at the data, the combined data, looking at stage 1, let's talk about stage 1, if you don't talk about the rest, just stage 1 lung cancer. All right? If you look at all the stage 1, if you start with 100 patients, you do your surgery, you do the best you can, we are at the end of 5 years, only about 50% of them are still alive. So in other words, stage 1 disease, even when you diagnose and you think they're stage 1 and you think that this is localized, you do a surgery, you think you've done a good job, still the cure rates are miserable. The answer in lung cancer is not treatment. We have made major advances in treatment. The success of treatment includes, but the most important thing is stop smoking. Are there smokers in this room? Please put up your hands. Don't be shy. Smokers? Three people put up their hands. 600 people, 3 people put up their hands. I can only draw 2 conclusions. There are very few smokers in Singapore, or Singaporeans are good liars. Marita is an example of a patient who presented with very advanced cancer. You can see on the PET scan, there's a very large tumor that can be seen. You know, what we did for him, he was in actual fact patient number 1 in Singapore to undergo a PET CT scan. I still remember the day he was sitting right in front of me. A phone call came in, and the PET scan said, hey, we are trying to commission the machine. Then there's 1 free dose for PET scan. You got any patient? I asked him, I've got free dose. Oh, free, I want. He's not Singaporean, but he thinks exactly like a Singaporean. If it's free, don't need to ask too many questions, just go for it. If the tumor grafting is free, we're going for it. All of us will go and do it. Okay? So he was treated with surgery up front, and then subsequently he went on he was given chemotherapy up front, and then subsequently went on to have surgery. To me, one of the biggest advances in lung cancer is understanding the molecular genetics of the cancer. Okay? Now we are able to identify a subset of patients that have got this particular mutation on the EGFR. Okay? Patients with EGFR mutation, they don't even need chemotherapy until much later. You can give them tablets. This tablet, Iressa, is a tyrosine kinase inhibitor. Not cheap, $120 a tablet, so $3,600 a month. So you're topped up your Medisave, Medishield, you know what to do, okay? All right, by popping the pill, the large majority of patients will enjoy a honeymoon period. They will have some response, they have disease control for a period before it breaks through again, and then you consider other options. Besides Iressa, there's Tarceva. All right? So there are many options that are now available for lung cancer patients. All right, this is an example of a patient. You can see the lungs are studded, pang, 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 pang. Hundreds of nodules. But thankfully, this patient carried the mutation. By taking the tablet, you can see the marvelous response. Okay? Sadly, this patient is no longer with us. In other words, much as she enjoyed a very good response, a near complete response, but it doesn't last. Within usually 9 months to 12 months, they lose its effectiveness, and then you've got to think of other options, and indeed chemotherapy becomes an option. Some of these lung cancer patients end up with bone metastasis. Look at them, pang, 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 all over. And yet with good treatment, this patient was treated with chemotherapy. You can see the marvelous response, everything is restored. This patient is also no longer with us. So much as we claim to have a lot of success in the treatment of cancer, this success is still not translated into significant change in the cure rates for cancer. All right. In the case of Mr. Barita, he's very lucky. He is cured. He has remained disease-free for almost 10 years. Sadly, about 1 year after she was diagnosed, his wife was diagnosed with lung cancer. And thankfully, up till now, she's still alive. Everything is okay. She has had one relapse, again responded well to treatment, still holding on. Breast cancer is one of those cancers that I think have made significant improvement. Because more and more women are aware of breast cancer. They're coming for screening. I know there's a lot of controversy as to whether mammogram should or should not be done. You know, some say yes, some say no. Gut feel is yes. Data now suggests maybe no. But don't worry about that. Soon we'll iron it out. But as far as I'm concerned, we should not change our policies in terms of recommending women to go for breast cancer screening through mammogram. All right? Kawai is not my patient. Kawai just happens to be in the calendar, and it was Dr. Khoo Kay Seong, my partner's patient. A node positive breast cancer treated with chemotherapy, alive and well. These are patients who, after surgery, will go on to chemotherapy. Even though there's no disease left behind after surgery, they take the chemotherapy largely to eradicate the microscopic disease and improve their chances of cure. But the truth is, much as Singapore is such a developed country, you would think that, look, you're only seeing all the easy cases. By golly, no. Look at this patient. All right? When she came and walked into my room, you didn't really need to see or examine her. You could smell the tumor. You can smell this smell of rotting flesh. Okay? And I smell it, I know it's there. All right? It may be in some hidden part of the body, but you know this patient is an advanced. And this patient, you would think, this one must be very poor, no education, maybe probably road sweeper, then you can get like that. No, she's not. She's an admin officer, works in our office, reads, writes, types. Okay? But her husband is a Taoist priest. And so what they do is that every day they pray. They burn the chopstick, they take the ashes, they mix it with water, and they drink it. And they pray for divine healing. And of course, this cancer grew and grew and grew. I don't know whether you can appreciate this picture. It's a bit too bright here, but, you know, literally, she says every day she just puts layers and layers of tissue paper. When people go for coffee break, she goes to the toilet, she strips off those pieces of toilet paper, of tissue paper, and puts on new layers. Every 3 hours, she has to do this so it doesn't soak through her clothes. That's how she's been living her life. And when finally I managed to convince her, you know, you can still see the tissue paper. I didn't do a very good job peeling it off, you know. All right. You can see after we treated it, he responded marvelously well. We subsequently did a mastectomy on her. And believe it or not, this patient is alive to this day. Okay? I wish I could bring her here and for her to tell the story, but she says, no, cannot. It's just, you know, it's something that she wants to forget. All right. One of the big advances in breast cancer is really the development, the discovery of the monoclonal antibody called Herceptin. In the patients who carry that particular cancer gene called HER2, you can use Herceptin both early as well as late breast cancer. And it makes a big difference to the outcome of patients. This is a patient, you can see this is a 70-year-old lady with a large breast tumor. The tumor is as big as my fist. Okay? And I told her, look, auntie, you need to have chemotherapy. Yeah, I know. I said, yeah, can we start? Yeah, sure. But one condition. I said, what's the condition? She says, I must not lose my hair. 70 years old, not afraid to die, but very afraid of losing her hair. So he said, you can do anything you want as long as my hair doesn't drop. My hair drops, I'm not coming back. So thankfully, there are indeed some chemotherapy programs you can give. You know, you can see, look at the big tumor before and after. You can see, I kept my promise. She kept her hair, and she finished her treatment. You want me to push it up higher? Put it on my collar. I thought I'm already so loud. The back still can't hear me. Can you hear me now? Okay, now you hear me better. So you can see, all right, now the drugs are so good that even when we've got conditions like no hair loss, we still can do it. This is a doctor from one of our neighboring countries, all right? To her, cancer is a death sentence. You know, as far as she's concerned, no need to see a doctor. So other than looking at herself in the mirror, I'm the only other doctor she has seen. And I told her, I said, look, you know, between the time you studied medical school and now, things have changed. There's a lot we can do even for someone like you. And indeed, you can see she responded well. She still continues practicing medicine to this day. That is how good we are in terms of helping to control disease, even when it's very advanced. This is another very interesting story. This lady, all right, She knew that she had cancer. She didn't want to have any treatment. And what she did was that the tumor was rotting away. It was smelly like anything. Every Sunday, the family comes for family dinner. I don't know how many of you have that tradition. How many still have family dinners on Sunday? Put up your hands. So few. Walao. Hey, it's a good tradition, okay? It's called family. I still have it, every Sunday tonight, after this, I must go home. And all the brothers will come back together. They bring their own families and eat together. That's what family is all about. Come on, stop listening to these stupid lectures. Just go and have family dinner. Hey, important things in life. This one is just for fun only, okay? All right, but anyway, she has got these family dinners every Sunday. All right? And the family, she would sit closest to the window, and she'll make sure that no one turns on the aircon, and the fan must blow towards her so that the smell goes out. So the family says, wow, your house smelly, She says, yeah, I think there's a dead rat somewhere, but we don't know where it is. And she'll keep up this lie. And she'll find fault with her husband. Every little thing she'll find fault. Why? Because so that she can kick him out of the room, so that he must sleep in the guest room. Because she didn't want him to know. So one day, the husband came back in the afternoon and found her lying in bed, looking very tired. So he says, look, what's wrong with you? She was crying. And she said, I tell you a secret. But if you tell anyone this secret, I promise you, I will jump out of this all HDB flat, Singapore all very high, I'll jump out of the window and I'll kill myself. And then she opened up and she showed her husband. The husband looked at it. He didn't know what to do. If he didn't tell anyone, this lady is dead. If he tells someone, she's going to be dead anyway, she's going to jump. So she struggled with it. I mean, I tell stories, they're all real stories. Don't laugh, okay? They're serious stories, okay? Pay attention. So he didn't know what to do. He thought about it very hard, And then one day he said, I don't know what to do. He couldn't sleep, he couldn't eat himself. He told the family, he went there and said, look, I got a bad problem. Mommy told me this. Okay, now, I don't know what to do. If you confront her and she jumps, I'm not responsible. Okay? But if you don't do anything and she dies, I'm also not responsible. I already ended you. So they came up with this story. So Sunday dinner came along. I got a bit of chest pain. He said, huh? You got chest pain? What, tomorrow we better go and bring her to see a chest doctor. Chest pain must see chest doctor, right? He said, yeah, tomorrow I go. You free? Yeah, you're free. Okay, Mommy, are you free? Mommy said, yeah, I'm free. I bring you along. Okay, we all go. And they brought to see this breast surgeon. Chest, same. Breast and chest, the same. So when they see this breast surgeon, registered the husband's name, and sat down. And so the breast surgeon was, what's wrong with you, uncle? No, not me. It's my wife. And she broke down. She cried. These are tears of relief. Finally, to have that burden lifted from her. To really, to hear that, look, finally she doesn't have to hide this secret anymore. The breast surgeon said, look, this is a very advanced cancer. I do a little biopsy, send you down to see Ang Peng Tiam. And you can see as we treated her, the tumor responded marvelously. She's operated. She's doing well. I like this kind of fancy stuff. So I did a nice poster picture for her, and I put the photographs down, the before and after, and I framed it up nicely and gave it to her. You know what she told me? Choy! She threw it away. She says, here I am trying to forget it, and you want to remind me, you want me to put this up in my home? You frame it nicely for what? So it just goes to show, much as I am proud of what I've done, as far as she's concerned, it's over. She still comes to see me regularly, but she really doesn't want to remember it. This is another lady, Japanese lady. Japanese ladies, I like treating Japanese. They're very good people, no? Are you okay? I'm okay. What's wrong with you? I got a small lump. Where's your lump? In my breast? Okay, let's go take a look. Wow! So I popped my head out the window and I asked the husband, hey, what do you do at night? He looked at me, I sleep. Okay, this lady has got advanced disease. You can see, massive disease, spread into the lungs, the bones everywhere. And after the treatment, she's still alive, but barely holding on. Thankfully, she has already finished her stint, 3-year stint in Singapore. They're going back to Japan. I don't know what they're going to treat her with next, because she's beginning to show resistance to treatment. Many people ask me, I've been an oncologist since 1986, started doing oncology from 86 till now, 20 over years experience. People ask me, have you seen any miracles? See, you're a Christian, right? You believe in miracles or not? So I say, well, I believe in the grace of God. Now, if there's ever one patient that I consider a miracle, is Esther Tan. Esther Tan is a very religious lady. She works as a school counselor. Okay? I'll tell you a story later. But the results of pancreatic cancer are horrible. They do very badly. Most of them are presented with very advanced stage disease. They usually die within 3 to 6 months. Not much to talk about. You know, even though we are now often able to find chemotherapy programs that can help them to get the disease better, look at them. This one has spread to the liver after surgery. You know, how they respond to treatment. They last maybe a year and a half, and at the end of the day, you know, we still lose the battle. These are the patients that we need to seriously think about. How can we improve on our chemotherapy program? What can we do in terms of selecting better drugs for them? How do we ensure that they get better results? As I told you, Esther is my only miracle. Histologically proven, that means we biopsied the liver, confirmed that she had pancreatic cancer spread to the liver. Given chemotherapy, all right, the disease from all these multiple nodules became one became fainter, and after that, we gave her treatment non-stop for 2 years. After 2 years, I told her, hey, I think we stop. We stop and we watch. When the disease comes back, we'll treat you again. But the marvelous thing is that never recurred. Don't know why. I don't try to pretend. I say, look, this is the grace of God. Right? She's alive, complete disease-free, sees me once every 3 months. Somehow, she never recurred. She's gone on to live life fully. She continues to contribute to society. She earns a meager salary as a school counselor, but nevertheless, she enjoys doing what she does. Colon cancer is one of those things where we try to detect it as early as possible. Stage 1, stage 2, your chances of cure are excellent. In the case of Mr. Gan, stage 3 disease, in other words, it's spread to the lymph node, up to 70% of these patients will recur. But the good news is, large majority of patients still present with very advanced stage disease. Early stages of cancer have got no symptoms. So in other words, you can have a lung cancer inside you now. You may not know it's there because there are no symptoms. Number 2, the symptoms of cancer are very non-specific, meaning you've got a cough. Maybe the cough is just because you've got a little bit of flu, a little bit of bronchitis, a smoker's cough, or it could be lung cancer. You've got a little bit of blood in your stools this morning, maybe it's just bile. Or maybe you've got colon cancer or rectum cancer. So because the symptoms are non-specific, it's very easy to find an excuse. The gastric pain is just gastritis, work too hard, too much stress. Or it could be stomach cancer or pancreatic cancer. Right? So sometimes people know, but they bluff themselves. Nothing this lump. Nothing like that. Day I bumped myself. You know, the husband was a bit rough that day. That's why I got bumped. You know, denial of symptoms. Some of them, they think, look, cancer is a death sentence anyway. What for I want to see a doctor? It's not curable anyway. No need to see a doctor. Some are very frightened of the side effects of treatment. And of course, in Asian society, a lot of people seek alternative treatment, like, for example, herbal treatment and so on. All right. I bring you back to my original story. Remember the patient I first saw when I was a young doctor? All right, that was his option. 5-FU leucovorin, you ask me what to do after that, I don't know what to do. All right. But now, look at these patients, very advanced. 75-year-old man, Mr. Chan, I still remember, wheeled into my room on a wheelchair. The eyes are bright yellow, tummy is so big, cancer all over. I said, uncle, 75 years old already, no? 搞了了. He said, give me a chance, doctor. We treated him. Marvelous response. Went on to live another 2.5 years before he passed on. All right? In the old days, limited. All you need to know, cancer, only one type, adenocarcinoma. Chemotherapy, very few drugs available. But now, you look at it. We don't just want to know whether it's adenocarcinoma. We want to know the genetics. Does it have wild-type KRAS or mutated KRAS? We've got drugs like oxaliplatin, irinotecan. I'm just trying to impress you. Actually, I don't know what they are also. Oxaliplatin, irinotecan, Xeloda, okay? We've got a whole list of drugs. And that's why it's so important to think about this concept of testing what works. If you've got no choice, what for you test? You've got no choice. Right? You've got one drug to try. You just try it. You've got nothing to lose. Right? But when you've got many drugs, and every time I try something, money. Every time I try something, it means side effects. Whether the treatment works or doesn't work, you still have to pay me. Whether it works or doesn't work, you still have to enjoy the side effects. If there was only some way whereby we can choose the drug and test it on somebody else or something else before we tried it on the human body, doesn't it make good sense to you? Especially when you've got many choices? In colon cancer, we've got many new developments. Like, for example, in the past, in the stage 4 colon cancer, you would never think of surgery for removing the metastasis. But now, we do, because it makes a difference. Now, we've got things like radio frequency ablation, where we just stick a needle inside there, use an ultrasound wave, and just burn and cook the tumor nodule. So we've got many options available for patients. When patients have got large tumors, we give chemotherapy, make them small, and then we burn them away. That's what we do for patients. So even in patients with very advanced disease, you say, look at it, the whole liver is literally packed full of tumors. But because there are options, there are drug options, some of these patients can still enjoy very good control of disease and prolongation of life. You give me any colon cancer patient, I got 60% chance I can make it go away. But it goes away, when it comes back, what do? My odds drop from 60 to 30%. I try again, it drops to 15%. If only we could test their tumors, not anybody's tumor, their own tumors, in an animal model, my life would be much easier. This is Auntie Lulu. Look at her. She came from the Philippines. She saw me on the 28th of May. And on the 29th of May, she went to Sentosa with the family. His whole family came to rah-rah her. Look at her face. This is what I call the look of death. The whole face is sunken. Look at her abdomen. Oh, almost as if she's pregnant. Look at the arms, they're all skinny. Look at the legs, they're swollen. These are obviously patients with very advanced cancer. Expected lifespan, less than 3 months. But look at the face. Look at the disease all over the liver. But when you treated her, she enjoyed a good 2 years of good quality life. Eventually, of course, we lost the battle. So people like Mr. Gan are very lucky. They have stage 3 disease. They go for chemotherapy even before the cancer has spread to other sites. And through experiments, we know that by using the chemotherapy after the surgery, we can improve on patients' outcome. My colleague just pointed out to me, the data for breast cancer using chemotherapy after surgery was proven in 1975. 15 years later, we found it in colon and rectum cancer. 15 years later, we found it in lung cancer. So for the 3 main cancers that we see, lung cancer, colorectal cancer, and breast cancer, the data is quite clear that after surgery, even though you don't have spread, a significant number of patients will benefit from chemotherapy because it eradicates the microscopic disease. So Mr. Gan is one of those lucky ones who had his treatment and lives to tell the story. This is one of my favorite topics. This is malignant lymphoma, cancer of the lymph node. You know a few famous people in Singapore who got it, right? Okay. Anyway, this is fortunately one of the diseases that we made very good progress. Patients do reasonably well, high chances of cure. Look at this patient with large tumors. Within days, look at the dates. 4 days later, the tumor is melting away. Before 3 weeks is up, you can see the tumor is almost gone. These are what we call highly chemosensitive tumors. In most cancers like breast cancer, colon cancer, lung cancer, you need combination of various treatments together to help to cure the patient. There are very few cancers that you can use chemotherapy alone and cure the patient. And lymphoma is one of them. Oh, look at this big bulky disease and how well they respond to treatment. So many of these patients, we always enjoy treating them because the cure rates are very high. It gives us a lot of satisfaction to help these patients get better. Okay, Mei Ling is one of those with low-grade lymphoma. It's a form of lymphoma that cannot be cured, stage 4 disease. But it doesn't matter, even though it cannot be cured. Nowadays, with the monoclonal antibodies that we use, we're often able to control the disease. She has been under my care for more than 10 years already. Nellie is a lady. She used to work in a bank. Found her job very, very stressful. How many people work in the bank here? Come on, bank officers. Pay me, I tell you. Good money, but very stressful. Very stressful life. Found with ovarian cancer stage 3. You know what's the cure rate for ovarian cancer stage 3? 25%. That means we try our best, do everything, do surgery, everything, 25 to 30% of patients are cured. All right? She's one of those who, by the grace of God, has been cured of her disease. She gave up her banking career and went into what she really loved to do. She opened a child care kindergarten. All right? And it says live the day. So basically what she's done is she's given up her career, she started her own business, and she lives life very happily now. And when you see patients like that, with life after cancer, you feel damn good. You feel they've really made a difference in life. All right, in ovarian cancer, this is what we often see. You see hell of a lot of tumor nodules, inside, pop. No, and all ovarian cancer patients need to go for surgery. It's only whether we want to take the time to discuss with them, hey, 75% of patients are going to recur. Would you like us to keep a tumor specimen for you in a mouth? Doesn't it make sense? If only it was $10, don't think you all need to think about it. But unfortunately, it's not $10. Okay? So that's why some of the things we need to consider later on. All right, again, you see ovarian cancer is a very chemosensitive disease. You see all the liquid after the chemotherapy, they all melt away. Oh, this is the latest one of the later patients I saw, came to see me just recently, December of last year. Ovarian cancer spread to the liver, to the bones. She already knew she had cancer for almost just under a year, refused to have any treatment because so afraid of toxicity. But again, we gave her the treatment. You saw the marvelous response. We just did this on the 11th of February. Oh, big disease responded marvelously. Remember, there's life after cancer, and we're not just interested in treating cancer per se. We treat the patient as a whole. We want to return them to normal life, and that's very important. This is another cancer that's very interesting. It's called germ cell cancer. This man was very interesting. He found to have a lump in the neck. They confirmed it was cancer. They told him, look, this stage 4 disease, we can help to control your disease, but it cannot be cured. Patient came to see me. We did some blood tests, found the certain cancer markers we reviewed. He has one of the most curable cancers in the world. And the pathologist looked at it, confirmed it, look, this is a germ cell cancer. Germ cell cancer basically is like testicular cancer. To me, the best cancer to treat, gives us a lot of joy, is testicular cancer. Mr. Ng, from a stage 4 disease, incurable, has been treated and cured of his cancer. This is my favorite slide. This is a young boy. All right, he was wheeled into my room, and the father laid him down. If you can't see, these are all the rags. They're very poor people from Batam, They use the cloth and just to wrap up the tumor, So the bleeding and so on, they soak up the juices, etc. Huge cancer. The family was told this one, no hope. But in actual fact, this patient has a testicular cancer. You see a big testicle? This is testicle. This is penis. This is the abdomen. This is what he looked like when he first came. All right. Okay, we treated him, and look at the result. Basically, the tumor melted away. All right, became smaller. The hole was quite deep. Slowly held the whole healed by itself. No surgery, nothing. It just healed. Look at his testicle, big testicle, smaller. No money, no scans. Don't ask me where the CT scan pictures. No money for the scan. Just made the diagnosis. Enough money to buy the medicine. Let's just do the treatment and do the best we can. And that's all we could do for this poor boy from Batam. Most important, look at the penis. No penis. Small penis. Look at the penis growing bigger and bigger. Very satisfying. Look at him. All right. He's a little Teochew boy, very cute. He runs around the room. He speaks to me in Teochew. I don't speak Teochew, but he speaks Teochew. One day he sat on my lap. He says, doctor, I'm going to study hard. I said, good. Study hard. Good. When I grow up, I want to be a doctor. Oh, good. Doctors are good. We can help a lot of people also make a good living. Oh, good. He got off the chair and then he turned his nose around and said, doctor, when I become a doctor, my clinic, I'm setting up opposite yours. I'm going to steal all your patients. This is him now. Grown up, strapping boy, doing well in school. But thank God he decided not to be a doctor. He's going to be an accountant. So he's going to count money instead. Okay? We've got many stories of encouragement. You look at this, this is our health newsletter. In case those of you who are interested, you can log on to our website. It's every month we put out a new health letter, health news to encourage patients and teach you all more about cancer. So do look into our website. This is a Filipino man who came to see me at the age of 38, stage 4 cancer, still alive 10 years later. This is Merlin, a lady with stage 4 breast cancer, alive and well to this day. We see some of the most horrendous cases. You really believe me. I'm finishing. This little girl, air flown in from Middle East on a respirator, big tumor, filled up the entire left chest, bleeding away. Every day we had to transfuse blood. I never give chemotherapy to people on a respirator, but she was one of those we did. Look at her. She's growing up. So you must be thinking, Dr. Ang, you're damn good, man. No need to talk already. Everyone cure one. What's there to talk about? Okay, now we play a little game before I finish off. Think of a number between 1 and 3. Make it your number. Choose either 1, 2, or 3. Remember the number. Okay, all done already? Everyone must do, huh? Okay, all those who chose number 1, stand up. All those who chose number 1, come on, don't be shy. All those who chose number 1. No, you're not playing the game. No fun, y'all. Sit down, everyone sit down again. Try one more time, last chance. Otherwise, I don't want to finish the lecture already. Think of a number 1, 2, 3. All those, please keep this as your personal number, either 1, 2, or 3. Okay? All those choose number 1, stand up. Okay, all sit down. Choose number 2, stand up. Walao eh. You think MCQ is it in school? A, B, C, choose B. So, choose number 3, stand up. Okay, thank you, sit down. All odds being equal, if your number is picked, you have a 1 in 3 chance. You saw how many people stood up for number 1. Number 1, somehow people don't want to choose. Number 2 and 3, if you stood up, you see how many people there were in the room. 1/3 of all Singaporeans will die as a result of cancer. So if your number is called, you have a 1 in 3 chance that you will die of cancer. All right? So this means that we are not doing a good job. Much as we tell you, look, there's a lot of hope, a lot of encouragement, a lot of new drugs and everything. If you're doing such a wonderful job, then why is it 1/3 of Singaporeans are still dying of cancer? There's still a lot for us to do in providing the psychosocial support for cancer patients. And we try to do our best in Parkway Cancer Centre. This is a very challenging aspect. We bring together the nurses, the doctors, the psychologists, the dietitian, the counselors. We bring everything together because we want to help people. That's why we've got this service that's called Can Hope. You can go and get the pamphlets. It's free of charge. You know anyone who's got cancer, wants a word of encouragement, we are here to help you in coping with the disease. All right? We bring together in Parkway Cancer Centre some of the top specialists, Melvin, the surgeons, the colorectal surgeons, and so on. We bring everybody together. Why? Because we believe that fighting cancer is not just a job for Ang Peng Tiam. It's a job that we need to bring together the best in the various fields. The pathologists, the radiologists, the surgeons, the gynecologists, the medical oncologists, the neurosurgeons, and so on and so forth. Because our aim is a very simple one. If the cancer is a cancer that's potentially curable, we want to do our best to try and cure it. If it's a cancer that cannot be cured, we want to do our best to try and control it, to try to preserve the quality of life and improve the lifespan of these patients. I started private practice in 1997. When I started, I was alone with 2 nurses, 1 receptionist, and 1 pharmacist. That's all. That's the size. Parkway Cancer Centre today is more than 100 people working together, doing our best for cancer patients. And we believe that as long as we all learn to work together, we will be able to not find the magic bullet, but at least help cancer patients. So our focus has always been public education. That's why I give lectures like this all over the place, community centers and so on, help people to understand what are the causes of cancer, how you prevent it, how do you detect it early, and what cancer treatment can do for you. And don't be like some of those ignorant people who believe that cancer is a death sentence, therefore no point in seeing a doctor. We continue to hope for new drugs to come in. Indeed, many, many new drugs are coming in. And now our problem is not the number of drugs, it is, but it's also how you choose the right drug for the patient. That's why we are very excited to collaborate with Champions Oncology to see what they can do to help us to improve our selection of drugs for individual patients. And obviously, we want to try to see how these treatments can be made less and less expensive for patients. Because the truth of it is the large majority of patients, they can hear about it, but they can't afford it. And that's very, very sad. So I'll take questions later on. Thank you, ladies and gentlemen.